think about him. So just by way of being appropriate here, Kevin Oeffinger is a family physician, professor in the Department of Medicine, and a member of the Duke Cancer Institute. He is a founding director of the DCI Center for Onco-Primary Care and director of the DCI Supportive Care and Survivorship Center. He has a long-standing track record of NIH-supported research in cancer screening and survivorship, and has served in a leadership capacity in various cancer-focused and primary care-focused national committees and organizations, including the American Society of Clinical Oncology, the American Cancer Society, and the American Academy of Family Physicians. He is currently an associate editor for the Journal of National Cancer Institute. So that's by way of his bio. But I think what I want to be able to say is that Dr. Oeffinger is probably what we call our go-to guy, but it's sort of a roundabout way of saying really the most knowledgeable, caring physician in the area of cancer survivorship, and particularly Hodgkin's survivors that we know of. He is a world-renowned specialist in the area of survivorship, and we owe a great deal to him for his research and his work on our behalf. And if you read through some of the articles in his bio, you will see just about every topic that we have ever discussed in this group in terms of late effects and cancer survivorship in general. So I think in terms of bringing everything we could possibly need and want to the table, he is our guy, and we are just very grateful to have you here. So thank you, and thank you for everything you've done on our behalf.
Thanks so much, Erin, and I really enjoy the opportunity to be back with the group. Much that you have accomplished, and it's nice to be on the other side of the pandemic now.
Yeah.
Last time we spoke, we were early in lockdown, so I hope that people are doing well. When Erin and I talked about this time, we actually left it pretty open of what we would discuss. I don't have any set slides or set agenda. I really wanted to be able to answer the questions that are on people's minds. You will be humored. Literally 2 minutes before this call, I was sending things to one of our grants managers. We have a grant that will go in to the National Cancer Institute within the next week. It's actually a grant focused on seeing if we can determine things through mammograms or breast MRIs that predict long-term risk for breast cancer among women who were treated with radiation at a younger age, before the age of 30, and using artificial intelligence and using machine learning. So very exciting, hopefully cutting edge. It's a multi-center study with Sloan Kettering, Stanford, St. Jude, and Princess Margaret up in Toronto, and led by Duke. So hopefully we'll see how that goes, but we think it's exciting science. We continue to push the envelope of trying to find things that can determine when somebody's going to have a problem 3 years or 5 years down the line. The common question that I always get from my patients is, when's the next shoe going to drop, or what's next? And our research really focuses on trying to be able to do exactly that, to be able to see what are the things that we need to pay attention to and what are the things that we do not need to pay attention to. So what I'm going to do now is just respond to chat. And you can send in your questions. Erin, you or Kathy or Rachel may already have something that you want to make sure that I cover, so you can start off. But I'll just try to answer questions in the hour that we have together.
We have a lot of questions. I'm getting some feedback. I don't know if that's coming from mine or we have a ton of questions, but I did want to just ask you before we got into the specifics about a couple more generalized things. And because I mentioned this also in the announcement that we're going to have you, just to give us a little bit of feedback about some of the articles that you've written and the research that you've done specifically around the area of, I'm thinking of the title of the article you wrote in December called "We Need to Do Better." And I wanted to see if you would comment on that and tell us a little bit more about what you mean by that and who that's really being addressed to, and whether or not you feel those kind of comments have an impact on other clinicians. I mean, I can tell you what I think it means, but I'd love to know what your intent was. And sort of, I did share that article with others, so hopefully many of you have read it and have an idea for yourself.
It's a great question. We calculated a few years ago the number of people in the US and Canada who would have had a cancer prior to the age of 30. That, in fact, I was trying to think, that probably was looking at just Hodgkin's. Mm-hmm. At that time, we were probably looking at just females, and I think we calculated it to be 50,000. So let's say it is Hodgkin's. Let's do both males and females and say it's 100,000 across the two countries. If you divide that out by the number of cities and the number of states and the number of provinces, et cetera, you recognize that by the time you get down to the individual provider, you are unique. And you know that from your experience. You go in and they say, gosh, I don't have anybody else like you. And what our goal is trying to get that information out to people, through our primary care providers, to our cardiologists, to our obstetricians. I had a wonderful 35-year-old Hodgkin lymphoma survivor 2 days postpartum a week ago call frantically because she had been short of breath, and they did a CT to look and see if she had a pulmonary embolus. And they said, no, but we think you have a new cancer. And she, of course, was frightened and, needless to say, crying on the phone. And we got the CT transferred to us, and actually it just looked like she got too much fluids during her delivery, and her heart didn't pump it as efficiently as it could have. It was basically just fluid backlogged in that. I talked with a physician. They were very grateful for the information we could give them. They diuresed her. She did great. She's very happy. Her baby's very happy. I'll see her next week and look at an echocardiogram. But part of that is that story, Erin, is how do we get that information out to providers when often our patients are the only patient like that they see. And that's why I always mention to our survivors, both locally and nationally or internationally, if you need input, if there's something that we can do to provide that, we are more than glad to. I look at ourselves sometimes as being more of an information source than anything else, or a liaison. And indeed, that's actually what we're trying to do at Duke through our Center for Oncoprimary Care, is link our oncology providers and our primary care providers across the full continuum for all cancers, not just one or two cancers, but both pediatric and cancers that occur to us when we're elderly, and everything in between. So that's a short-ended.
That was one of my questions, was to see if you could talk a little bit more about the primary care initiative and what kind of implications it might have for other areas of the country and also for other countries, because there's been a lot of research on how other countries are faring with follow-up care, and there seems to be information that's all over the map about who's doing what, and often doesn't seem like there's a centralized model of care.
There's not, and I don't anticipate that there will be, because the models of care are really dependent upon the locale, the resources that one particular group will have, the personnel, things of that nature. And as I see a lot of the chatting questions going by, a common one is, how do I pay my bills?
Yeah.
In the US, this is a huge issue. Both in being insured and even when being insured, having large deductibles. And I encourage our patients to work with the financial person at wherever they are seeking care. Believe it or not, a lot of times institutes, cancer centers, primary care physicians' offices, all of those sort of things, if you are showing an effort to pay bills, and that can be as little as $5 a month, they will work with you. There are different groups that provide resources for people that don't have them. I mentioned last time, we've been doing breast cancer screening studies for the last many years. And one of the things that we mentioned is Christina Applegate's foundation. She has a group called Right Action for Women, RAW. And because she was a gene mutation carrier that had breast cancer at a young age, she feels very committed towards providing imaging at a no cost for individuals that are at risk and are younger than the age of 40. And so they actually partner with a number of radiology groups across the country to be able to provide no cost or low cost breast MRIs. That's incredible. And you can actually just go to the Right Action for Women website, look at the information. What they need is your last year's IRS form, or if you're on Medicaid or Medicare, your letter for that. And they are nonprofits, so they need that information to maintain their nonprofit status, but they'll work with you. So there are groups that can help out with areas of that. I ordered an echocardiogram for one of my patients that actually had a thoracic spinal tumor. And she messaged me back through our system and she said, hey, I looked at getting it at such and such a place and it was going to be $3,700. So I shopped around and I found another place that will do it for such and such, and my insurance will cover it to this amount, and we do it at that place. And that just reminds us that whether it's prescriptions and calling different pharmacies, or whether it's imaging studies and finding out where you can get a good study at a reasonable price, that often requires a partnership between both the patient and the ordering physician or providers and their financial services. But I encourage you to be empowered, to be activated and speak out for yourself. If you move to Canada, or certainly if you live in Denmark or the Netherlands, there are much better safety nets, if you will, for patients that are cancer survivors and the care that they need. And unfortunately, in the US, we have a very fragmented system that's become very politicized. Fortunately, the Affordable Care Act does make possible having coverage outside of the standard employer-based coverage, but recognizing that even that can be very expensive, and we recognize that. The last thing that I'll say is when I see my patients, and I may have 4 or 5 things that I think that are worthwhile doing, I'll prioritize them with them. I'll say, this is what I would like to do over the next 12 months. You give me a sense of how quickly you want to do them. And I'll also tell you how quickly I think which ones need to be done. And we can partner along those lines. And so sometimes we'll actually try to get a lot of things done prior to the December 31st when new insurance plans kick in or new deductibles do.
Kevin, there's a question here about, how often to have mammograms or breast exams. And I before we get to that specific one, I think a lot of us have had the problem with having to convince our provider that these tests are necessary. So, and that goes back to the inability to have a standard model of care for survivorship, where there are some general recommendations about how often we need mammograms or CAT scans or echocardiograms. So what can you make a general suggestion about how to deal with the fact that there really isn't anything to fall back on in terms of our, other than going and saying, I need to have this done, see I'm at risk for heart problems?
So I think there's probably 3 things I would say. Number one, there is, as many of you have encountered, kind of what I refer to as the eye rolling syndrome. You tell your provider what you need and they go, oh, sure.
Yeah.
So part of it's education. And if you find that your provider is not someone you can educate, vote with your feet. If you have that option. Certainly, if you don't have that option, that makes that a little bit more difficult. But vote with your feet by finding a primary care provider or a specialist that will work with you. We did that actually in one of our studies recently, where we're trying to increase breast cancer screening rates. And I had one of our participants from the Buffalo area reach out to us, and their provider had the eye rolling experience and said, is there anything at Roswell Park that I might go to? And so we got her plugged into Roswell Park's Survivorship clinic. And she wrote back just as pleased as she could be. And they were wonderful. And they help again with having the financial information to be able to provide to patients for that. So be empowered and vote with your feet. Second thing that I'll say is that we are always working on how to write that information for insurance companies. For breast cancer imaging, it's very easy. There's a single box that the insurance company or Medicare is looking for, and that is that the lifetime risk of breast cancer exceeds 20%. It's actually based upon a misinterpretation of work that we published from the American Cancer Society years ago. But nevertheless, that's kind of the box, if you will, that insurance companies use. The average woman, the woman at average risk for breast cancer in the general population that doesn't have any of these risk factors we're talking about, is 12% over their lifetime. So it's not quite doubling of what that risk is. Virtually everybody that was treated with radiation that included the chest area prior to the age of 30 exceeds 20%. And so that's all we write in the insurance is this person is at risk. And in fact, there are even codes within our billing system that say at risk for breast cancer or at risk for cardiovascular disease. And those are acceptable codes by insurance carriers on there. The third thing that I'll say is I'm always cautious with the use of risk calculators in patients because people outside of medicine often don't understand the concept of risk. It's very abstract in a sense. But in a sense, what we're trying to do is say, if I followed 100 people over some time period, this is how many people out of that 100 would have whatever problem I'm thinking about. And that gives us some metric to be able to compare groups across. If you Google CCSS, which is our acronym for the Childhood Cancer Survivor Study, if you Google CCSS and then St. Jude, it'll take you to our website that has all of our information for healthcare providers. And within the far right-hand column, there's one that actually talks about calculators. And the calculators, we are always trying to develop calculators that are meaningful to our patients to predict heart problems, cancers, things of that nature, so that they can educate their healthcare providers. So we have one there on there for heart attacks and heart failure. We have one for breast cancer, thyroid cancer. We're working on one for menopause, a variety of other things that we have in there. And you can actually put in whatever information you have and it'll calculate out a risk. Now, I always caution people, and the way I explain it to my patients is, if I was to go to Las Vegas and bet you're not going to have this, I'm going to win a lot of money because the odds are in my favor that you're not going to have such and such a problem. If I say that 10 people out of 100 are going to have it, that means 90 out of 100 are not. But we're not going to Las Vegas and betting on the odds. We don't have a crystal ball. We can't tell whether somebody is in that 1 or that 90. So for example, if you want to calculate your cardiovascular risk, most primary care providers and cardiologists in the US will use a risk calculator that's called ASCVD, atherosclerotic cardiovascular disease, ASCVD. And that's based upon a very famous study called the Framingham study, which is a cohort study, which simply means we follow a group of people over time. And it takes the Framingham data and then some other cohort studies and pools it together. And that's why people refer to it as the pooled cohort equations. And from that, you can calculate what your risk is of a heart attack or a stroke over the next 10 years. And that is the calculator that most people will use to determine whether or not to start a statin in the general population. But if I calculated Erin's risk, it's way off because what it doesn't include is her radiation. It includes, whether or not you smoke and have diabetes and hypertension, et cetera, but it doesn't have anything in there about having had radiation to your heart. And so within the CCSS, Eric Chow, one of our pediatric oncologists at the Fred Hutch in Seattle, Eric and our group developed a risk calculator for heart disease and heart failure with some limitations. It's easy to predict somebody that's in their 30s, but we don't have the time frame for our studies that predicts somebody that's already in their 60s. But you can still extrapolate. That gives you a rough estimate, if you will, on that. So whenever I go and talk to a healthcare professionals in the US or Canada, I always show them the example of a Hodgkin survivor. If I calculate their risk of a heart attack using our traditional method and how it underestimates their risk, and instead use one of our risk calculators that's designed for our survivors and how that informs our care. So that's the second thing is our risk calculators at St. Jude through the CCSS. The third thing is the Children's Oncology Group guidelines. Melissa Hudson and Wendy Landier have led this effort now since 2003. So we're going on almost 20 years. We update those guidelines every 2 to 3 years. You can Google Survivorship guidelines and it'll take you to that website. It is a very cumbersome PDF. That's just the way it is. Nobody gave us a ton of dollars to be able to change it otherwise. But you can look through your exposure. So let's say that I was treated with involved field radiation to my mediastinum and my neck, and I also had ABVD. I could look up A and find out what was what they recommended for adriamycin, B for bleomycin, V for either the vinblastine or vincristine, and the D for the dactinomycin. And then for radiation in the areas that were involved, it will tell me what I should have. So sometimes we can create our own plan just by knowing what our treatment information is and going into that. Sometimes you can alert that to your provider and ask them to do that. I will guarantee you'll usually get an eye rolling if you're the only patient like that provider is seeing, because they're also seeing tons of diabetics and hypertensive patients and patients with this and that and whatever. And to be able to spend the time and go into that PDF and be able to decipher it is beyond what time frame most people have. So again, be empowered, get your own information as you can on that, vote with your feet. Go to the CCSS website for our risk calculators. And we think that they're good for basically anybody treated prior to the age of 30-ish or so. And then the COG guidelines, which actually are part of our international effort we formed a number of years ago that's called the International Harmonization Guideline Group. We try to harmonize our guidelines across different countries.
Yeah, Kathy put that in there as well, asking about the harmonization effort. So given what you've just said, and knowing that not everyone will have all of their information, we hear this a lot. I couldn't get my records, they don't exist anymore, they're on microfiche or whatever. If you have a woman is asking how often should she have a mammogram, would you have to say it depends on what kind of radiation you had and how? Okay, so
if you had radiation to the chest area, we know that risk can be high enough, and it's interesting for us from an academic standpoint what high and ultra high risk is, but to a patient, it doesn't matter. Here's the recommendation. And that's the way that I would go. So I still, as I mentioned in our last get together, I typically recommend doing both of those imaging studies once a year. You can alternate them by 6 months. We don't have good evidence in any of our populations that that makes a difference, but there's a theoretical benefit that if I have an interval cancer in between my imaging, then I'm more likely to catch them. I always tell my patients, if you're OCD like I am, do it every 6 months, alternating the two studies. If you just like to get it done at one time, hey, that's fine. Just do them both on that same day. We do have alternatives for patients that can no longer have a MRI because of the type of pacemaker or metal they may have in their body on that. And we also are not far off from having our fast MRIs and maybe our fast MRIs without contrast. So things are happening in those areas. And the whole goal of the grant that I just told you about a moment ago is I'd like to know factors that suggest somebody's risk is elevated enough that we would counsel on other options if I knew the risk in 5 years, not just trying to diagnose it. I see a couple questions on statins. I'm gonna do a risk benefit. So with everything we do, there is a risk and a benefit. I actually have a risk sitting my butt in this chair right now rather than exercising. I made a decision, this is more important on there. So the benefit's very high on there. And the risk is not that big a deal because I'm just sitting in my chair for an hour and I did my exercise this morning. Every decision we make, we have a risk and a benefit. I get into the car, I'm going to go drive to the grocery store. I have a risk of somebody running a red light, which happens plenty of times in Durham as well as it does in New York. So I wear my seatbelt. It is a law, but I still think it's a smart thing to do. And I pay attention to what I'm doing. So there's a risk to me having injury, but there's also a benefit of getting to my groceries. Same thing as every imaging study that I talk with our patients, I say, here's what we're trying to do. This is what we're trying to determine. Here's the potential benefit. Here's the potential risk, so that people can be educated and informed in making their own decision. The same thing goes with medications. If I decide that I want a medication for my cholesterol, I have to say, what's the risk of my cholesterol? In somebody that had radiation to the chest area, it's substantial. I've had 29 and 30-year-olds with heart attacks. I've had 20-year-olds with breast cancer. So the risk is there. It's uncommon at that age, but it happens. And the older somebody is, that risk continues to increase. That's back to what I mentioned a moment ago about our risk calculator. There was a very interesting study that was done by the United Kingdom a few years back, led by an epidemiologist named Tony Swerdlow, that showed that if somebody had Hodgkin lymphoma and had a heart attack, their likelihood of dying of that heart attack was 3 times more than somebody having a heart attack in the general population. That's interesting, that if you had Hodgkin's and you had a heart attack, your risk of dying was 3 times more likely than somebody of the same age and gender in the general population. The reason is because our radiation fields include those parts of the coronary arteries that are so critical to the rest of the heart, what we call the left main and the proximal left anterior descending coronary arteries. And those, if they get blocked, can lead to sudden cardiac death. And we've all known patients that have had that. We're trying to prevent that with the best of our ability. So again, risk benefit. I have a risk for cardiac disease, and I can be reasonably precise in some of our risk estimates. Somebody having a little bit elevated and somebody having a lot elevated based upon our calculators. What's the downside of statins? Well, certainly some people will have some side effects from that. They have muscle aches. They might even get some inflammation of the muscles. But generally working with somebody, we can get around most of those side effects, that they're reasonably minimal for about 97% of the population. 2 or 3% of people will really battle with them, and we have to look at what our options are. Sometimes it may take a trial of different medications to see what somebody tolerates the best. Needless to say, Exercise that lowers the cholesterol makes a big difference. Our diet makes a big difference. So if I talk about the amount of exercise, I'll repeat what I did last time. We've got great studies that show 30 minutes, 5 days a week, moderate intensity exercise, so a light sweat, saves lives. 30 minutes, 5 days a week. You can break that into two 15-minute segments. So walk in the morning, walk in the afternoon. If walking is an issue, and you can do water aerobics or yoga, where there's so many different things people can do. We published a paper in one of our cancer journals a few years back that showed that our Hodgkin survivors that actually had 20 minutes a week of vigorous activity had a lower risk of death of heart attacks than those that didn't follow that guideline. 20 minutes in a week of vigorous activity. And so we figure out what our body will allow us to do as far as physical activity. With respect to diet, I'm a believer in the Mediterranean diet, or the other thing we call, referred to as the 5 alive, 5 servings of fruits and vegetables. So 5 servings about the size of your fist of fruits and vegetables, or something that has less red meat, more fish, more olive oil, things of that nature. So the Mediterranean diet or the 5 alive diet, exercise, combined sometimes with a statin, and saves lives. And sometimes imaging, we can quantify somebody's risk just based upon our imaging. So if they really don't want to go through a statin unless it's totally necessary, we can do a special type of CT scan that is less invasive than a cardiac catheterization and be able to quantify somebody's risk of a heart attack in the next 5 to 10 years. And that may be the extra information they need to make that decision.
Kathy just asked about, I don't know if you can say this specifically, what is the targeted LDL for us, or is it 60?
It's a great question. We will likely never know. My preference is an LDL below 100. Scott Grundy is an endocrinologist at UT Southwestern and was the leader in a lot of the cholesterol studies through the US over the years, and had a seminal study that showed years ago that if you took people that had already had a heart attack or at very high risk for a heart attack, there was no such thing as too low of an LDL. Even if you went from an LDL of 80 down to a 70, you actually still had benefit. And if you went from 70 down to 60, you still had a benefit. But most of us set that target of trying to get it down below 100.
Before I know there's going to be a lot of hard questions because that has been a hot topic in this group. But there was an earlier question, Kevin, about colonoscopies, kind of along the same line of breast cancer screening. What can you recommend for us in terms of regular colonoscopies?
A great question. When our patients have had radiation to their chest and their neck, they always know it. They remember very vividly. But I've been always surprised that a lot of times people have had abdominal fields and they may not have realized it. And our tattoos, our radiation tattoos, don't answer the question. Back to the whole question of record keeping is radiation oncology centers often keep the radiation records longer than anybody else does. So you may not find it in medical records, but if you actually call the radiation oncology center where you were treated, they often can find those records. At Sloan Kettering, ours went back to the 1950s. But even in community settings, sometimes I've been able to find records back to the 60s. So that can be helpful in knowing. There are patients that had an abdominal field, so below the diaphragm, and the fields that we typically had is what we call a para-aortic, so near the aorta. It's the lymph nodes that go from the diaphragm down in a rectangle to the belly button. That field, and we often used to include the spleen and occasionally the liver, or where the spleen was after it's taken out. And then sometimes patients had nodes in their groin that were involved, so they went down into the groin area, and we call that an inverted Y. Any of those fields, somebody should have colonoscopy starting 8 years after their radiation or at age 30 or older. And we typically do it if they don't have polyps every 5 years. You can probably get away with FIT testing, which is a fecal immunoassay test that works good, and your primary care provider can order that. And it's cheaper, obviously, than a colonoscopy. So that is an option for somebody that doesn't have the finances to get colonoscopy. We think it works well in the general population and probably does fine in our cancer patients too as a screen. If it's positive, then somebody has to go on for a colonoscopy to be definitive to that. Now, an interesting population is our patients that were treated with MOP or COP, MOPP, or COPP, or some of our hybrids around that. One of the P's is for procarbazine, and it's a oral chemotherapy that our Dutch colleagues realized actually causes colon cancer apart from our radiation. So sometimes we had patients that just had radiation above the diaphragm, which hopefully shielded the colon and their abdomen, but they got the COP or the MOP or the procarbazine. And we have seen we have seen some of our patients developing a special type of polyp that we call a serrated polyp, serrated sessile polyp. So sessile meaning flat against the wall of the colon, and serrated, it's kind of a jagged edge. And so I've talked with our GI groups, both here locally and nationally, about paying attention to our Hodgkin survivors that were treated with procarbazine. That I've seen a number of those patients that tend to have 10 to 15 to 20 polyps per colonoscopy, and sometimes need to have colonoscopies every year to be able to take care of that. So that's our area to take care of colon cancer. If you do your colon cancer, breast cancer surveillance, you've taken two big cancers that have late stages that can be deadly off of the track and can identify things either in an early stage or even a precancerous stage.
I mean, we had a couple of minutes ago someone who specifically had that issue with the serrated asked and said that she was told that her colon was cleared after colonoscopy, that nothing was removed, and questioned how can they disappear and how soon should she have her next scope. So is that possible? They can disappear on their own, or?
No, they don't go away. We don't see polyps regressing. They may not have been seen if the prep was inadequate or the visualization was inadequate. So they typically remove those polyps. A gastroenterologist can be quite good and adept at removing 5, 10 of those at a time with that. And if we see a serrated polyp, I tend to do it every year until I know there's no polyps, and then go to every 3 years.
Okay.
And to be a little bit more on the conservative side. Remembering what you all know also well is you've already gone through cancer therapy. And while our cancer therapies for colorectal cancer are different than what we had for Hodgkin's, it still is a burden on the body. And if I can keep from somebody going down that pathway by my surveillance, that makes a big difference. And anytime somebody runs into a barrier, they're welcome to email me and copy their provider and say, see their provider and say, hey, if I reach out to Dr. Oeffinger and copy you for his input, would you mind? And we see people doing that all the time, and I never mind that. And I respond by simply giving a little bit more information to the gastroenterologist or the cardiologist or the breast surgeon or whomever.
Kevin, there's also some related questions from Paul and Sophia and some of your well-known colleagues and patients about other kinds of gastric issues, reflux, swallowing, Barrett's, bowel obstructions. We do hear that a lot. More and more,
Sure
particularly swallowing issues is becoming a very common complaint, and respiratory paralysis.
Even with our contemporary doses of radiation, I think at some point in time, we'll see people having similar. We won't see the strictures with contemporary therapy because we've lowered our doses. Back in the 70s and 80s, we often treated with 45 to 54 Ray or 4,500 centigrade, 4,500 rads to 5,400. And that sometimes, and some people would call as an actual scarring of the esophagus or a stricture, requiring somebody to have a gastroenterologist dilate that periodically. With our lower doses, we don't see that, but we still see swallowing problems, and we see them for a variety of reasons. We see them because if the field involved the mantle, the lower part of the jaw area, it involved the salivary glands, so people don't make as much saliva. Also, it involves the nerves that run along the esophagus. And I describe to my patients when I see them, we have two sets of nerves around the esophagus, one that's around it like that, and then one that's lengthwise. So you can imagine the nerves that are pushing the bolus of food down and constricting it, and they work in conjunction. So if I swallow some bread, that's the mechanism that's getting it down. So if I'm low on saliva and those nerves aren't working in conjunction, you can imagine I'm going to have more problems with swallowing. So what we always tell patients is a few things. One, I recommend to people to drink a room temperature water, a third of a glass before they have their first bite of food. In my years of recommending that, maybe 1 out of 10 people take me seriously and do it regularly, maybe 2 out of 10. And the others go, oh yeah, I know I should do that. I just forget, and I'm really hungry, and I start eating, and then I start having problems. But it's a very easy thing to do. That room temperature water gets you a moist mouth, and it gets the esophagus starting to work. So it primes the pump, if you will, on that. Chew well, don't talk as you eat, drink plenty of water as you go through that, and eat slowly. Those sort of things can help. And then sometimes we end up having to have somebody go through swallowing retraining with one of our speech therapists, and they can be very, very good at retraining people how to swallow properly with it. Sometimes we need to work it up a little bit better with an upper endoscopy to make sure that everything looks okay, or with what we call a barium swallow, where you swallow this chalky, yucky stuff that they do with a videogram to watch and see what happens to that as it goes down. So my experience with the swallowing is it's a nuisance problem. Different than the people that have abdominal field radiation and just have a lot of GI complaints, which we really battle with weight management, keeping weight on there. But the swallowing tends to fall into the nuisance area.
In terms of the gastric, Nancy asked the question, how common actually are gastric lymphomas as a late effect? Is that?
Gastric lymphomas are very, very uncommon, rare. We will see gastric carcinomas, which are also fairly uncommon. Basically, in the radiation field, we can see any kind of tumor. And I've seen both very common types of tumors, and I've seen really oddball, once in a career type of tumors with that. And what I tell our patients is really two, maybe threefold. One is, you know your body. If something feels different, make sure you talk to your provider and that they're hearing you about what's going on, not being poo-pooed, if you will. Two, learning to deal with that sense of uncertainty. And we've talked about this in the past. But every one of you knows the data in this area, and it can scare the stink out of you. And you can choose to live your life scared, or you can say, you know what, I'm going to live with a certain amount of uncertainty and move forward and do the best that I can. That actually leads to the third area. We've got a group of psychologists at Duke that are really quite good at doing cognitive behavioral therapy. And so they go through a variety of different training sessions to help somebody. Part of that's using meditation, but a lot of other things that help us to get our fears where they don't take control of us. but we keep control of them to the best of our ability. And most areas around the country now have psychologists that are trained in teaching cognitive behavioral therapy, or we abbreviate it CBT. There are other ways to lower that those fears and uncertainty, but those are just some ideas along that way.
Just a quick question before we leave, or maybe more of a comment. I think that what a lot of people struggle with is the slim line between having your fears overtake you and not being believed by your provider. And I think when we get a reaction that's a poo-poo or an eye-rolling thing, and are made to feel like we're being silly because we've got a fluttering heart and we're just overreacting, help us to figure out the best way to manage that. Am I being a worrywart, or am I not taking a sign seriously enough? Should I be doing something about it? Because that's a real tough.
Yeah. We are, I think I probably used this expression before, but the world is a bell-shaped curve. You remember when you were in high school, you learned about the bell-shaped curve distribution. So whether it's height, the average height for a male is about 5'8", 5'9". I'm shorter than that, but still within that bell shape. And there's some people that are 7 feet tall and some people that are 5 feet tall, and it's normal. And it's the same in our response to our fears. Some people are deniers. And that's actually when I get more concerned, is when a patient doesn't pay attention to anything because they deny it can happen. And that's when we get into problems, because sometimes it's too late. And then some people are on the other end of the spectrum that are constantly feeling parts of their body. And you have to learn who you are and how to handle either of those ends or somewhere in the middle with that. I tell my patients, and I believe this firmly, is that there's no such thing as a hypochondriac cancer survivor, and there's no such thing as a stupid question or a dumb question. Now, that doesn't mean the provider you're seeing is going to feel the same way, but you know your body, and I do encourage our patients to be empowered and to say, you know what, I know that you may not be thinking this is anything, but this is different for me. Again, you vote with your feet. Your provider is whoever you choose. It's not who they choose, unless you're in an area that has limited number of providers with that. And work with people. If you go into an office visit and you have 20 questions, the likelihood of getting them all answered is small. You go into an office and you have 2 questions, you now, by their human nature, you can get that accomplished. And then over a period of time through your patient portal or other thing, get some of the other questions answered. So hopefully that's helpful. I've also seen a lot of the questions on head drop, musculoskeletal, et cetera.
Wow, that head drop.
That's to have, you have Michael Stubblefield, come on.
Yeah.
Michael knows this area as well as anybody. What I've tried, I've pushed Michael for years, and you can hold his feet to the fire. I still think that you could prepare a 1-sheet note that goes out to everybody that says, these are the basics. And he said, well, it's a little different for this person and that part, but there's still basic issues that you can or should do. I think that there's a few things. One is staying active with the upper part of the body, and the exercises that I have seen that seem to make the best difference with that is, I'm a real believer in yoga. Yoga seems to be quite preservative to the upper extremity muscles with that. People that swim, which most of us don't, and I would include water aerobics and that. Simple walking. One of my favorite patients I followed for many years at Sloan Kettering had serious head drop syndrome and came in like that. And he would walk probably 4 to 5 miles both ways to work. And over a period of a year, he came in with his head fully upright, just from walking, because we do our arm swing. Light weights with whatever our shoulder does can make a difference. I had one of my New York patients was a figure skater. She had the best looking neck I ever saw of a Hodgkin survivor. She's doing all this incredible stuff on that. I don't know that any of us can replicate that. But those are simple exercises. There is a brace, a couple of braces that Michael recommends that I can send to Erin that she can circulate to the group. But you have Michael on the thing and Q&A him about other things you can do for muscle restoration. It is slow, but it is in part reversible. And the more important part is can be preventable by early intervention. And physical therapists that are knowledgeable in this area can be exceedingly helpful.
We hear from folks about the neck brace, Kevin, some who say that doesn't really work and that you're not teaching your muscles how to support, your head. If you use it, it's kind of like a cop-out. What's your thoughts on that? I mean, is it meant to be restorative or just supportive, or what is the purpose behind the neck brace?
So it can be both. It just depends upon where somebody is in that continuum. I saw two patients recently in my own clinic. One is a young man that's a real DIYer, do-it-yourselfer. And I was ready to hire him. He was telling me all the projects he did, and it's absolutely amazing. And his greatest frustration is he's starting to lose strength in his neck and his upper extremities. And his fear is that he won't be able to do the projects he likes to do. And so you can already realize that he has done so much that preserve things longer than it might have otherwise, but that there's additional things that we can do on top of that. So I referred him to one of our physical therapists that can work with him. I saw a patient a week later that actually came in with true drop head syndrome. We've got a lot of work to get that head back up. In my clinical experience, I've seen maybe now a dozen and a half, 2 dozen patients with true dropped head syndrome, truly neck down. And sometimes we can get that to being back straight, and sometimes we can't. We can do to the best of our ability to get it to a reasonable thing. So prevention always is better. So for people that are on the Zoom that are younger or treated with lower doses, start now. I start my patients exercising as they're in their 20s and 30s and really emphasize that. And you do the best that you can.
Kevin, I'm going to use a little segue here. Give you a second to look at some of the questions. And at the same time, I want to give a shout out to your colleague, Sophia Smith. Sophia, if you could unmute yourself and maybe show us your beautiful face. We can see you for a minute. Sophia happens to be not only a colleague of Kevin's, but she's also a board member of Hodgkin's International. And I know you two have done a ton of research together and published several papers. And I just wanted to recognize both of you as the team that you are for what you've done. And Sophia, I don't know if you want to comment at this point, but
thanks, Erin. It's been such an honor working with Kevin, and also I'm one of his patients. So when I used to see him up in New York, I used to make the trip from North Carolina to New York City just to visit with him. In fact, he developed my survivorship care plan. I never had one, even though I was treated at Sloan Kettering so many years ago. And you can imagine how delighted I was when he came to Duke. So I see him every year and we go through, my latest lab results, and he's been helping me with this more recent side effect of the colon polyps and how to manage that. In fact, I think I saw a message from someone asking how often they should go if they had procarbazine. So I'd encourage you, if you haven't had one yet, to go. And then whoever your physician is who does the colonoscopy, they'll be in a better position to tell you how often you should go. So I started out every 3 years, and then as my polyps increased, now I go every year. and she removes them. It's painless. It takes, the procedure takes less than an hour. Frankly, the most difficult part of it is the prep that you have to do beforehand. But if you're not in an area that has a survivorship clinic, certainly feel free to email me. I can help you find one. As Dr. Oeffinger said, there's many late effects that we may be at risk for. Breast cancer is another late effect I had in my 30s. So I get the annual mammogram and the MRI every year, and Dr. Oeffinger offsets those by 6 months. And then, heart, he watches that, and I'm on a statin just to keep my levels low. So it's really, it's an ongoing effort, and I'm just so grateful that we have Dr. Oeffinger to not only advocate for us, but also to see us and make sure that we continue to have good quality of life. So, yeah.
Just a quick question that, so colonoscopy wise, what about like the mail-in thing? Is that like not, can we do that, or are we too high risk for that?
It's reasonable if finances are an issue, or having a colonoscopy is too much of a risk. So it's a reasonable alternative. I apologize too. I've got a 3 o'clock strategic planning, so I'm going to run to that. I will say that the feeling is mutual. I get way more out of talking and working with all of our patients than they get from my care. So recognize that I'm a fan of all of your roles. And so wonderful to be on with the group. Erin, anytime I can help out, let me know. And I really apologize. My day is just wall-to-wall Zooms.
We're grateful. And the rest of you, if you can stay on for a bit, we'll try to answer some more questions amongst ourselves and have a chance to chat. We'll use the time together. But Kevin, thank you from the bottom of our heart. You're terrific. We appreciate it. Take care.